Hi, everyone. My name is Kelsey Shane. I'm the Marketing Director at the Canadian Digestive Health Foundation, and I'd like to welcome you to our webinar this evening, Hot Off the Presses, the latest IBD information from scientific meetings with Dr. Silverberg. The objectives for this evening are to review the most recent scientific findings in IBD and to understand the role of diet and gut bacteria in IBD. For those who may not know who CDHF is, we are the official foundation of the Canadian Association of Gastroenterology, which means we are directly connected to Canada's leading digestive health experts, physicians, scientists, and other healthcare professionals. So you can trust us to provide you with practical, science-based information that is up-to-date and unbiased. This webinar has been made possible through an unrestricted educational grant from Takeda, so we would like to thank Takeda Canada. Just a few housekeeping notes. This is a live presentation. During it, if any questions come to mind, please enter your questions in the question box at the bottom right-hand side of your screen, and questions will be addressed at the end of the presentation. If you do not see the form, just click the Ask a Question hand icon on the top right of the screen, and someone will be standing by to help you. Our speaker this evening is Dr. Mark Silverberg. Dr. Silverberg's medical practice is devoted to the care of patients with IBD, so he was an awesome speaker for tonight's presentation. He leads research programs aimed at identifying the causes of IBD and is engaged in clinical trials to identify new therapies. So without further ado, I would like to welcome Dr. Silverberg to the webinar.
All right, good evening, everybody. Thank you very much for the opportunity to speak to you, and what my plan is over the next 30 to 45 minutes is to review some research that's been presented at recent meetings on inflammatory bowel disease that might be of interest to the patient community that's affected by IBD. Primarily, the work that I'm going to be speaking about was presented at a meeting called ECHO, the European Crohn's and Colitis Organization, and that meeting took place in early March of this year. So these are the objectives, as I just mentioned, to review some recent scientific findings related to inflammatory bowel disease that were presented at the ECHO meeting. And in particular, we'll cover some studies related to a hot topic on the role of bacteria and how it is affecting the course of inflammatory bowel disease and how diet might affect the role of bacteria in IBD. So as you heard, this event is supported by the Canadian Digestive Health Foundation as well as Takeda, which is the company that manufactures Entyvio. You already received my background. I'm a gastroenterologist at Mount Sinai Hospital, University of Toronto in Canada, and I've been working in clinical care of inflammatory bowel disease for nearly 20 years, and also run a research lab aimed at understanding the genetic and bacterial and environmental factors that lead to inflammatory bowel disease. So as I mentioned, what I'll be presenting tonight were related to presentations made at the European Crohn's and Colitis meeting, which is one of the largest meetings for inflammatory bowel disease annually and attended by international physicians and investigators from around the world every year. So the first study that I'd like to tell you about is a treatment trial, and I've sort of changed the wording a little bit to try to simplify it and make it understandable for a broad audience. But this study is related to a medication called Stelara, or its generic term is ustekinumab. And this is a medication that's currently available in Canada for Crohn's disease treatment and not yet available for ulcerative colitis. And this study is part of the program that is being undertaken to assess the efficacy and safety of Stelara for ulcerative colitis. And in a prior meeting, the initial results related to Stelara treatment in ulcerative colitis were presented looking at what we call induction effect, or the short-term effectiveness of Stelara for ulcerative colitis. And that was a study that did show that Stelara was an effective treatment for ulcerative colitis. And this study is what we call the maintenance study, which tries to demonstrate how effective a medication is over the longer term, usually out to approximately 6 to 12 months, to show that the medication can work both for getting an initial flare-up under control as well as to be able to keep people in remission once they're treated. So the background and aim of this study was to see whether Stelara, which is already proven to be effective for Crohn's disease, would be effective for ulcerative colitis, and in particular in this study to show that it could maintain remission after 52 weeks of treatment. Now, the type of patients that were included in the study had to be patients who generally failed other therapies. It could have been conventional treatments like prednisone or other steroids or immune suppressants like Imuran or methotrexate, or other biologic therapies like Remicade or Humira, and ones that you may have heard of. And these patients had already received one intravenous dose of Stelara as part of that early study that I told you about that showed that it was effective in controlling the initial flare, or the initial approach to treating in people who are having a flare. And what they looked at is whether in the patients that responded to that one intravenous dose during a flare would be able to stay well over a 1-year period following that initial treatment. And the way that sort of study is done is that those responders to that initial dose are randomly placed into 3 groups. Those groups would have been to get a Stelara injection every 8 weeks for 44 weeks. And the second group was Stelara 90 milligrams every 12 weeks for 44 weeks. And the third group is a placebo group, which means they did not receive the medication during the follow-up period. So to give you the results, there were 523 patients in total, which is a fairly good-sized study for this type of treatment study to see if the medication is effective. And the results showed that patients in both the every 8-week group receiving Stelara as well as the group receiving Stelara every 12 weeks did better clinically, which means from a symptom standpoint, as well as endoscopically better compared to patients on placebo. And what that means is that when we look at clinical outcomes, we're looking at symptoms. So things like patients, how many bowel movements they had in a day, how much bleeding they saw in their stools, how well they felt overall. So that's one of the outcome measures that we look at in trials is how people feel. And then the other outcome was related to what we call an objective outcome from a colonoscopy that would have been done at the end of the study period to show that the bowel itself was healed more significantly than it would have in a patient that only was on a placebo. So those were very positive outcomes. And the other result that's assessed in these trials is related to the safety of the medication. And this study showed that there was no increase in side effects in patients receiving the medication as compared to placebo-treated patients, so suggesting it was as safe as a placebo. So the conclusion is that both the dosing regimens of Stelara, whether it was given every 8 weeks or every 12 weeks, was more effective than patients not receiving the treatment over a 1-year time period. And in essence, really showing that Stelara was as effective in ulcerative colitis as what we've seen in the past for Crohn's disease. So this is an important study and a very promising result that adds the potential for another medication to our armamentarium to treat ulcerative colitis. And this medication is undergoing regulatory approvals now, with the hope that it might be available to patients in clinical practice sometime perhaps in 2020. So that's very encouraging and provides us with another treatment option for patients with ulcerative colitis down the road. So that's that first study I wanted to talk to you about. The next study is called the Varsity Study, and this was it's entitled A Randomized Controlled Trial Comparing Entyvio to Humira in Patients with Ulcerative Colitis. So this is an important study because, as we just discussed, there are more and more treatments that are becoming available for ulcerative colitis, which is a good thing, but it does raise the dilemma of which one we should consider using, and let's say as the initial choice of treatment. And there are now multiple options, and it's becoming difficult for physicians to, choose which treatment they would like to give first. So what this study looked at was comparing two approved medications for ulcerative colitis to see which one would do better. We refer to it as a head-to-head trial. It would seem obvious that this is an important thing to do, but there really are not many examples of medication trials that are being compared head-to-head. So this is actually one of the first ones in inflammatory bowel disease and the first one in ulcerative colitis to compare two approved treatments. And the goal was to see which patients would have done better after 1 year of treatment. And so in this study, patients that were included would have failed what's known as conventional therapy. So that's, again, medicines like prednisone or azathioprine, Imuran, and those medicines, meaning they weren't effective and the patients needed additional therapy. So again, this was a randomly ascertained trial where the patients didn't know what medication they were going to receive, and they were randomly allocated to receive either Entyvio or Humira, and not know which one they were on to see which one would do better. And so these are the results. There were 769 patients in this study, which is, again, a very good size for a trial like this to try to show a significant outcome. You could see roughly equal distribution between Entyvio treated patients and Humira treated patients. And the result of this study showed that patients who received Entyvio did better endoscopically, again, like I mentioned before, based on a colonoscopy score at the end of the trial, and had higher clinical remission rates, again, which means that the symptom rate was better in the patients on Entyvio as compared to Humira at the end of the trial, which is at week 52. And similarly, like I described in the last study, we look at the safety elements and side effect rates, and in this study there were no significant differences in the rate of side effects between the two groups. So the conclusion of this study was that Entyvio worked better than Humira to get patients better, and both were found to be safe and well tolerated. So this was interesting because Humira is used quite frequently in ulcerative colitis, and perhaps may lead to a shift for some physicians to use Entyvio a little more. It does not mean that Entyvio is going to work for all patients, and it doesn't mean that Humira is not a good treatment choice. But they do work by different mechanisms of action, and so there still may be scenarios where a physician may choose to use a particular drug like Humira or Remicade over a drug like Entyvio. But this is a study that does suggest that in an average patient population, which covers over 300 patients per group, that Entyvio did seem to be more effective than Humira in the broad sense. So it may lead to alterations in the order in which treatments are given for ulcerative colitis and which one might be prescribed first or second. But as I mentioned, these studies are not necessarily something that you should say, well, in all cases, one drug should be chosen over another, but rather it gives some guidance to physicians in general terms of which ones they might choose to use over another. So that's all I'm going to say about that study. And again, at the end there'll be a Q&A session where I can take some questions if there are any about the some individual aspects of the study. All right, the last two studies that I'll talk about relate to our other objective tonight, which is to discuss the role of gut bacteria in inflammatory bowel disease. And this is, as I mentioned, becoming a very hot topic with a lot of interest in understanding the role of the environment and diet and how that could affect the course of IBD as well as potentially treatment. So this is sort of an interesting study that looked at a particular element of bacteria, and in particular, it relates to the role of gut bacteria in psychological elements of inflammatory bowel disease. So just as a background, we know that patients with IBD are more significantly affected with psychological distress, with anxiety, with depression, and there's certainly components of that related to the actual disease that are in terms of how severe the disease is and how much it affects a patient's life. But there's also an increase in the rate of these types of conditions, even in patients whose disease is well controlled, and we don't really know why that is. And what this study hypothesizes is that could the role of gut bacteria and the kind of compounds they produce in the gut affect depression and anxiety in IBD. So what this study did is they looked at patients who filled out surveys and questionnaires to assess their scores related to the degree of anxiety and depression and how it affects their day-to-day lives. And they were placed into three groups based on this. So the first group had mild to moderate anxiety or depression on their scores. The second group had severe anxiety or depression based on the survey, and the control group had no anxiety or depression related issues. And what this study showed was that there was a decrease in gut bacterial diversity in the patients who had more anxiety and depression versus those that did not. And what bacterial diversity means is that in a healthy situation with a healthy gut, we expect there to be a very diverse microbiome or composition of bacteria with many different types of bacteria. That's a healthy situation for the bowel. And when there's decreased diversity, it suggests that or it's associated with a more unhealthy situation, meaning there's less species, less diversity in the population of bacteria found there. And that was found to be a significant result related to the risk of anxiety and depression in patients that had less diversity in their microbiome. And in particular, when looking at depression in a more granular way, so dividing the groups with mild to moderate depression versus severe depression, there was no major difference in gut diversity. So it didn't affect the severity of the depression, but more just the presence of depression, whether it was there or not. So to conclude, there was an association between anxiety and depression in IBD and the diversity of gut bacteria found, and that they suggested further studies would be needed to look at the functional reason for this, so the understanding of why this happens and how we could use this information to treat patients better. And whether it is the actual presence of the bacteria or lack of presence of certain bacteria, whether it's the substances that the bacteria metabolize that are related to anxiety and depression. So just really what we call hypothesis generating type of study. It's a great interest, but a lot of further work needs to be done to understand how to use this information better for patients down the road. The last study that I'm going to talk about, I think it's the last or second last, is also an area that's quite a hot topic, and it relates to using something called fecal microbial transplantation, or FMT, as a treatment for IBD. And this is now becoming quite mainstream, with numerous studies assessing the role of a fecal transplant to treat IBD. Just briefly, what in general, fecal transplants can be done in many ways, but overall, what the general approach is that healthy donor stool is collected, and this can be done in many different ways, but usually, of course, the patient, the donors, the healthy donors are screened for infectious diseases, and to make sure that it's safe to be given to another person. And this is a fairly intensive process that's done by screening the patient as well as the stool sample itself, with the idea that if someone's healthy, that their gut bacteria are potentially protective or therapeutic to someone who is affected by inflammatory bowel disease. So there's been some early promise that FMT type of studies have shown some improvement or some effectiveness in treating patients with ulcerative colitis and Crohn's disease. So in this particular study, was done by a group in Japan, and what they looked at was the role of a fecal transplant in ulcerative colitis, but comparing two groups. So one group received what was used as a triple antibiotic therapy for 2 weeks, and this was done to try to sterilize the gut before the sort of healthy donor fecal transplant material was given, and that was administered by a colonoscopy. So that's how the fecal transplant study was given. And the other group received only antibiotics, but not the fecal transplant, to see what the actual benefit of the fecal transplant alone would be on patients. So the results of this study showed that the group of patients that received both antibiotics and fecal transplant had better outcomes in their ulcerative colitis response than patients who just received antibiotics alone. And they also did colonoscopy, so similar to the other studies that I talked about earlier, they looked at both the symptom scores as well as colonoscopy scores, and found that there were improvements in both of those types of outcomes, both for patients that received fecal transplant and antibiotics as compared to only antibiotics. So that's also an exciting result. In this study, when they looked at the type of colitis, they did show that the patients with proctitis, or colitis that's restricted to the rectum only, actually had an even better result than the general colitis population in the study. So that was also interesting to note, because this is a patient population that often is more refractory or more difficult to treat. And that's sort of the study, and the conclusions were that the combination of antibiotics followed by a fecal transplant is a promising treatment approach in ulcerative colitis, and there are ongoing studies in Canada as well as elsewhere in the world to look more carefully at this and to see what the reasons are and how this could be rolled out in a more broad way to see if this could be an effective treatment strategy for IBD. And there's one more study that I have to finish up. So this study, so along the lines of what I just talked about with a fecal transplant, if we believe that gut bacteria are important in IBD, as we do, how else can we change that bacteria aside from a fecal transplant? And another way is by dietary approaches. So the question is, can administering a certain type of diet or oral intake can that shift the gut bacteria in a positive way that would help patients improve without the need for medication, possibly? And so this is an area, again, that's increasing in popularity, and there's a lot more work being done in our field to understand the role of diet in treatment of IBD. And this is a study that was done with a very particular approach. It was in Crohn's disease, and it happened to be in pediatric Crohn's disease, so children with Crohn's disease. And what this study did is took children with active Crohn's disease and compared two different dietary approaches. One approach was called exclusive enteral nutrition, which is a liquid-only diet that's used mainly in children and not too often in adults. But it's a treatment approach that's difficult for children, but has been proven to be effective at inducing remission. Using a specific formulation and not allowing the patient to eat any type of regular food, but only using a liquid formula that's specially designed to meet the caloric needs of the patient. And they compared that approach to something called the Crohn's disease exclusion diet. And this is a term that's been coined by this group of researchers that did the study. It's a group from Israel. And what they did is they compared the exclusive enteral nutrition approach to patients given this Crohn's disease exclusion diet, which is a whole food diet. And it also did include some partial liquid nutrition component with it. But basically, it was designed to be a more, let's say, tolerable diet because it allowed whole food. And I can give you a little bit of information about this exclusion diet, because I'm sure that's of interest. This is a diet that excludes sugar and processed foods. It reduces the amount of carbohydrates, but allows complex carbs more than simple carbs. It encourages a small amount of animal fat and protein and a larger, more plant-based approach to the diet. And those are sort of that's a simple, simplistic kind of view of the general approach. But I would say the key elements to it are reducing sugar, especially added sugar, and reducing processed foods. So that was the two groups that were included in the study. And so this is just, again, to summarize the methodology. So the first group for the first 6 weeks was given that Crohn's disease exclusion diet based on whole foods, and they were supplemented with liquid nutrition for the first 6 weeks. And then in the second 6 weeks of the study, they progressed to having 75% of their calories given with the Crohn's exclusion diet and only a quarter of their calories by liquid nutrition. So that group was compared to the second group, which I explained, that was given only the liquid enteral nutrition diet for the first 6 weeks, followed by a slight liberalization of their diet in the second 6 weeks, where they were allowed to eat whatever they wanted and still given 25% of their calories as liquid enteral nutrition. So that was the study design. And the results of the study showed that the whole food-based Crohn's exclusion diet was significantly more acceptable to children. 98% of them found it acceptable and easy to do versus only 73% of the kids that were using the exclusive liquid diet. And the rates of poor compliance with the diet were similar, although a little better for the patients that could eat whole food at 17% versus 23% in terms of how poorly they followed the diet. And in terms of outcomes on their Crohn's disease, the Crohn's exclusion diet-based treatment group had significantly more children in remission at 12 weeks compared to the children who were given only a liquid-based diet initially. And the results showed 70% of the children with the Crohn's exclusion diet were in remission as compared to 41% on the exclusive liquid diet. So, and the last point of the results was that both studies, both diets did show a significant decrease in inflammation and a good outcome in terms of remission without the need for steroids. So it does show that actually a purely nutrition or diet-based approach can actually lead to very good outcomes comparable to prescription medication in this situation. So both diets did reduce inflammation. The whole food-based Crohn's exclusion diet was more acceptable and actually did give better outcomes than a purely liquid diet that's been used more traditionally. And so this data actually shows that this could be used as a first-line treatment for children with Crohn's disease. And this has been a much more acceptable approach to treatment in children than in adults traditionally, but I think you'll see over coming years there's going to be more and more attention on a diet-based approach to the treatment of Crohn's disease and ulcerative colitis over the next few years. So that's my final slide. Hope you found that information interesting, and I'm happy to take questions if there are any.
Perfect. Thank you, Dr. Silverberg. That was a super informative presentation. We did have a couple of questions come through. So the first one, I know you talked a little bit about the nutritional therapy and the plant-based diet. Pierre asks, a lot of people I know use plant-based diets to help control IBD symptoms, even when in remission. What are your thoughts on this, and are there any studies to explore this coming down the pipeline?
Yeah, so far most of the diet studies that have been done have been looked at induction of remission, meaning people flaring and seeing whether they can improve with treatment. But I do actually agree that maybe the most valuable role for a diet-based approach will be in maintaining remission once remission's been achieved with medication. And so there aren't yet data to show that that can be done, but there are studies underway in various settings to try to see if we can understand what type of diet would be best and how it might be used to maintain remission. So I think we're going to see better science around that. And I would say one of the challenges in recommending a specific diet is that I would say the initial scientific evidence suggests that it might not be the same diet for every person with every disease. So although in general we talk about a little bit more of a plant-based diet or a Mediterranean diet, low sugar, low processed food, anti-inflammatory diets, it's not quite certain that that's going to be a general approach that's going to work for everybody, and it might turn out that we need to look at the specific bacterial, let's say, deficiencies in a particular patient and try to prescribe, if you will, a diet that will be better for certain individuals. So that's probably much farther down the road, but certainly the initial studies looking at a more general diet approach are underway, and we'll see a lot more data on this over the next couple of years.
Okay. And then this might be another personalized question too. His follow-up question is, when doing the exclusion diet, do you recommend taking probiotics or consuming foods that typically diversify the gut bacteria?
Yeah, so probiotics are a good question. I didn't mention that. So there are different ways to change up the microbiome. One is diet, another is a fecal transplant, a third is probiotics. And actually, interestingly, I would say probiotics right now are probably the least effective of the three approaches. And I think although probiotics have been around for the longest as a strategy, one of the issues around existing probiotics is they're randomly kind of put together with what's thought to be harmless bacteria, usually a small number of species, usually quantities that are not sufficient to actually engraft and change the microbiome, and often not in a way personalized or targeted. So So there's a lot of probiotic products available that are probably not effective, that are probably not having sufficient live bacteria and not being taken in the quantities that are needed to actually shift the microbiome in a positive way. So for now, I really would not, I can't recommend any particular probiotic product as something that's effective, but as with the other areas, there are studies that are starting to be done with newer products, different products, and products that are a combination of both a probiotic as well as a fecal transplant to try to enhance the type of bacteria that are in the product and to really allow a shift in the microbiome that might be positive. So for now, I'm not recommending probiotics very often, but I do think down the road there'll be a resurgence in different kinds of probiotics that might turn out to be more effective.
Okay. And another question here from Robin. In terms of research focusing on IBD, gut bacteria diversity, and anxiety depression, is it realistic to hope for advances in managing mental health by focusing on diversifying the gut microbiota, even outside of just IBD patients?
I would say it's realistic, but my own instinct on it is it will be a little tougher to change the microbiome in a way that's going to affect mental health. Probably a little further down the road to understand that relationship. I think in the study that I presented, it's a little hard to dissociate the bacterial composition from the IBD-related changes versus pure mental health-related issues. And there are other areas of research outside of IBD done by psychologists and psychiatrists that are focusing on the non-IBD-related mental health aspects of gut bacteria. And you probably heard about lay press articles that have talked about, relationships between gut bacteria and ADD, attention deficit disorder, or depression, or even schizophrenia and other mental health disorders. So I think it's going to be a separate field that will evolve and probably a little tougher to figure out that connection, but there's certainly no shortage of research being done on mental health both in the setting of IBD as well as on its own, and understanding how diet and the microbiome may help with those issues.
Okay. And our last question, Celeste asked, does fecal transplant not have any benefits for people who suffer from Crohn's disease?
So I would say right now there's a little more data to show that it's effective in ulcerative colitis, but there are ongoing studies to look more carefully at fecal transplants for Crohn's disease. One of the issues around Crohn's disease is that it can be very the heterogeneity of the disease is quite significant, and so people with, let's say, Crohn's of their small bowel, to see whether a fecal transplant would help, would have to undertake a study where we really can administer the bacteria more directly to the area affected, and that's a little more difficult if the Crohn's is affecting the small bowel in the middle. It's harder to get at it and really ensure that the bacteria are getting to the targeted area. Whereas in ulcerative colitis, because it affects primarily the large intestine, it can be given by enema, and it's just easier to get the treatment or the microbial transplant right to the affected area. It's easier to measure outcomes as well in ulcerative colitis. So I don't think we know as much yet about Crohn's disease and microbial modulation, but I am fairly confident that there will be an important role of microbial modulation in Crohn's disease. It might just have to be done through a different means, more likely a diet-based approach or a supplement-based approach as opposed to a fecal transplant.
Okay, interesting. So that's all the questions that we have that came through. I'd like to give thanks to Dr. Silverberg for taking the time to present today, as well as to CADA Canada for allowing us to do this awesome presentation. And I should mention that this webinar will be available on cdhf.ca in the next few days, just for anyone that wants to review or share the content, feel free. So that's all. Have a good evening, everyone.